Okay, so today we'll just continue with the female reproductive hormones. That's the next thing to talk about. And we'll start with the first one, which is estrogen. So you guys need to know that there are three different sources of estrogen. It can come from the ovary, it can come from the placenta and the adipose tissue. And each each one of these structures give rise to different form of estrogen because we have three different forms. We have the estrone. So you guys can just the way I learned it is just by looking at what ent it. So estrone one, estrone, estriol three, estradiol two. So estrone is the one that comes from the adipose tissue. The placental secrete estriol, and the ovaries secrete the 7 beta estradiol. And they vary in the level of potency. The most potent one is the estradiol from the ovaries. That's the most potent. Then followed by the one from the adipose, which is estrone, then the one from the placenta, which is triol. So the majority of the one that is doing the major function is the estradiol that's coming from the ovary. And you guys remember that the um that I mentioned that estrogen is important in the development of the internal and external genitalia in females. That is development of the internal genitalia, including the fallopian tube, the uterus, the cervix, and the upper vagina, and also the external genitalia, which includes the vulva, the glands, clitoris, and the other structures. And at the same time, estrogen is also important in development of the secondary sexual characteristics in the females. So you want to they want to achieve uh, fat distribution in the right places, maybe around the hips and development of the breast. Because I don't want to say development of the pubic hair and the axillary hair because that one is actually function of testosterone. You guys remember that testosterone is also being produced on the ovary, and it can help with the axillary hair growth and the pubic hair growth, which is part of the secondary sexual characteristics. But the part of the secondary sexual characteristic that the estrogen modulates is growth of the breast, growth of the breast, as well as fat distribution, to bring out that feminine figure and shape. Then it's also important to know that estrogen is involved in the development of the follicle, especially during the menstrual cycle. The growth of the follicle is being coordinated by the FSH and estrogen. And estrogen also stimulates the development of the uterus. Maybe I should just classify it. So when you are looking at the ovaries, you are looking at the follicle, follicular development. When you are looking at the endometrium of the uterus, it proliferates the endometrium. That is, it allows for hyperplasia of the endometrial cell. We have to separate that from what progesterone does. Progesterone is just stimulating the secretion of the endometrial gland, making them secrete mucus, and also engorging and enlarging the spiral arteries which perfuse the endometrium. But if you want to increase the number of the endometrial cell, that is, you want to achieve endometrial hyperplasia, you are not touching the gland, you are not touching the artery, it's just the cells that are there, the endometrial cells themselves. That is what estrogen does. Endometrial proliferation or hyperplasia, estrogen. Then on the myometrium, it facilitates, myometrial contraction, myometrial excitability. So it's a very, very useful function of estrogen, especially during the process of labor, so that you can contract the myometrium and bring the baby out. Then estrogen also increases, the upregulation of estrogen receptors, the luteinizing hormone receptor, progesterone receptor. You can know this, though it might not be very important, but you can know it. Just that progesterone here in the reverse will downregulate estrogen receptor. Estrogen will upregulate its own receptor, upregulate LH receptor, upregulate progesterone receptor, but progesterone downregulates estrogen receptor. So progesterone is anti-estrogen. I'm going to mention it when I get to progesterone, but the more I reinforce it, the better it stays in your mind. So then estrogen also inhibit FSH, we of course, and LH. That one is normal, just the normal feedback mechanism. Estrogen, exert a feedback effect on FSH and LH. But before ovulation or very close to ovulation, there is estrogen surge. There is increase in the level of estrogen, and that reverses the normal effect of estrogen on LH. The normal effect of estrogen on LH and FSH should bring them down. But like 12 to 24 hours prior to ovulation, you have an increase in the level of estrogen, which is coming from both the ovaries and developing follicles. And what they do is to stimulate an LH surge. So before you can have an LH surge, you will have had a sharp rise in estrogen too. So that LH, that sharp rise in estrogen, just few hours to ovulation brings about LH surge that brings about ovulation at the head. Then importantly, estrogen stimulate the anterior pituitary gland to release prolactin. They release prolactin, but the effect of prolactin on the breast is inhibited until the estrogen level is cut off following delivery. So when initially during pregnancy, estrogen causes the anterior pituitary gland to be secreting prolactin, but it inhibits the action of that prolactin on the breast to achieve lactation. But once you deliver the placenta, you separate the placenta from the baby following delivery, and there's no estrogen supply again. That inhibitory effect of estrogen on prolactin is, is lost. And prolactin can stimulate the breast and bring about lactation. Guys, I've mentioned this stuff before, but there was a day that we were talking about action of prolactin on dopamine. So I was saying if you separate, if you deliver the placenta, you have, less estrogen that can. I don't know if you guys can remember that lecture. There's a lecture that we're just
Yeah, I
confused
think
about.
it was a question we did that made that explanation come out or
Okay,
something.
okay. So, but this is the actual mechanism. It actually increases the level of prolactin secretion. It's just that it's the action of prolactin that is inhibited until the estrogen is lost. Then, of course, estrogen, like we know, just like someone that is using OCPs, they increase the level of the transfer protein. The sex hormone binding globulin, the thyroid hormone binding globulin, the cortisol binding globulin, the three of them, sex hormone, thyroid binding, as well as the cortisol, you know, they are increased with increase in estrogen. That's why if you give someone OCP or if someone is pregnant, they can have elevated levels of this transfer protein. And of course, estrogen is very, very good for the cardiovascular health because it helps to increase the level of HDL and reduce the level of the LDL. So that is why people that are postmenopausal that are at risk of developing coronary heart disease, you want to give them hormone replacement therapy with estrogen containing pills so that you can upregulate the level of HDL that they have and then regulate the level of LDL. I know that it might be difficult for you guys to memorize this, but I feel that if you see it in the question, if they ask you and they prompt you, you should be able to, like, if they ask you that what's the effect of estrogen on FSH and LH, you know it. You might not be able to say it, but seeing it in questions, you'll be able to know which is which. Because I know that it can be very, very, difficult to arrange in the head. So yeah, so then another important factor is to know that during pregnancy, there's a 50-fold increase in the level of estradiol and estrone. So the one that we use to check fetal well-being is the one that is coming from the placenta because the person is still pregnant. So the placenta is actually the one that is dominating the production. So, and it's about 1,000 folds of estradiol. So someone that has, more than 1,000 folds, you know, a very high level of estradiol. So it shows that baby is doing well. So the one that helps to keep the baby well is
Dr. Babale, is it just, you're actually talking very fast?
no, I'm not talking fast though.
That's the way he talks, I think so.
Because
Hello,
I'm finding it out to even follow what you're
I think
saying.
we are trying to catch up, Sha.
hello. You said what?
What did you say,
I think
Dr. Isha?
we've been trying to catch up.
Ah, so I'm actually fast.
You, like, to me, Sha, maybe
Naturally.
because I don't understand. I'm just learning this here, Sha.
Ah, okay. Let me slow down. Let me slow down. Let me slow down then.
Dr. Babali is used to taking us before, after we have done something. So it's easy to catch up. But if it
You
is new like
get,
this,
I guess that's the issue. I guess that's it. I
Oh,
guess that's it.
yeah. So guys, I will have to relax. I will have to relax. So okay. So, but
Thank you very
what
much.
I've been saying initially. Okay, so let me just continue. Let me just continue. So, I said that in pregnancy,
Okay, so Dr. Babale, please, can you
yes.
start from the part of prolactin and dopamine? I think I lost you from that point.
No. I was just trying to make reference to that one. I didn't actually talk about it. I just said that the effect of estrogen on prolactin is to increase the production of prolactin from the pituitary gland. That's what it does. But
So dopamine, I didn't get that.
I've not mentioned dopamine. Keep dopamine for now.
Okay.
So what I said is estrogen.
Prolactin, pituitary gland.
Yes, so estrogen stimulates the pituitary gland to produce prolactin.
Okay, I get that now.
Now the catch that is now there is that prolactin does not work because of estrogen. So estrogen inhibits the action of that prolactin on the breast, so they will not lactate when they are pregnant. Do you understand?
Okay, so estrogen causes prolactin release,
Okay,
but
secretion.
that same estrogen is preventing the letdown, right?
So it's preventing the action. It's not let down. You know that let
The
down is
action of that prolactin. So even though there is prolactin, the prolactin is not working.
yes.
Okay.
So the reason why I said it's not let down is that it is oxytocin that is involved in
Oxytocin that
prolactin.
is let down. Yeah,
So
oxytocin is let down. Yeah.
lactation is prolactin. So there won't be lactation. So in pregnancy, you have a 50-fold increase in the level of estradiol and estrone. Estradiol is one that is coming from the ovaries. Estrone is one that is coming from the adipose tissue. Um, in During pregnancy, the best one that you want to check for is estradiol, and you expect a 1,000-fold in the level of estradiol in a pregnant woman that the baby is doing well and is alive. Because it shows that the placenta is actually working to keep that baby perfused. So there's a 1,000-fold in the level of estradiol from baseline when the mother is not pregnant. Then it's important to know that some um, receptors for some lipid hormones like estrogen, like your adrenocortical hormones, thyroid hormone, vitamin D. They Some of them have their nucleus in the cytoplasm. Some of them have their nucleus in the some of them have their receptor rather in the cytoplasm. Some of them have their receptor in the nucleus. So any one of them that don't have their receptor in the nucleus have it in the cytoplasm, so that when the hormone finds its way across the cell membrane, you know that when they say an hormone is lipophilic, that means that it can cross the cell membrane. That's what it means. So if they cross the cell membrane on the cell they want to act on, they bind to their receptor in the cytoplasm, and the receptor hormone complex translocate into the nucleus and bind to a specific DNA domain, that encodes a particular protein that hormone wants to express. Let's say that estrogen now wants to upregulate progesterone receptors. Progesterone receptors are proteins. So, and you know that DNA encodes protein. DNA will undergo replication, it will undergo transcription to mRNA. mRNA will be transcribed to protein. So estrogen will go to the cell it want to act on. It will enter into that cell, crossing the cell membrane and bind to estrogen receptor in the cytoplasm. So that estrogen receptor complex will now translocate into the nucleus and activate the segment of DNA that encodes the protein that it wants the body to express. Another hormone that works like that is thyroid hormone. Another hormone that works like that is vitamin D. It can come out in your exam.
And I think steroid hormones generally, Abby.
Yeah, steroid hormone generally, but I'm not sure of progesterone. That's why I didn't mention it. So I'm sure of estrogen.
I know vitamin. I've seen vitamin A in a question.
Yes, vitamin A,
Retinol. Yeah.
vitamin A, vitamin D, estrogen, and the adrenal cortical hormone. So yeah. So the next thing, let's move to the different cells that are found within the follicle. So a follicle is just like a cell that is surrounding the ovum. So inside the follicle, you have an ovum. You can see this small thing, guys. This small thing is the ovum. So surrounding the ovum are the follicular cells. So what are the two major cell types that makes up the follicular cells? The inner one, which is a
Dr.
granular cell.
Babawale,
Yes.
sorry to disturb you. Progesterone, estrogen, testosterone, cortisol, aldosterone, thyroid hormone, and vitamin D.
Yes, yes.
So progesterone is among, and then the cortisol, aldosterone, T3, T4, and vitamin D. They have intracellular
Receptor.
receptor and they enter the DNA. Yeah.
Yes. So that's good. Thank you. So the inner cell ones, which is the granulosa, and the outer cell ones, which is the thecal cell. So it's important for us to appreciate that I've mentioned it before that the granulosa cells are the homologue for the Sertoli cells. The homologue of the thecal cells is our Leydig cells. So from there we can infer that thecal cells can produce androgens while our granulosa cell can produce um, uh, estrogens, because Sertoli cells can produce estrogen too, and our Leydig cell can produce testosterone. So what happens? What happens? So at puberty, when there's a lot of hormones being produced, LH, when there's postnatal release of GnRH, so it can stimulate the anterior pituitary gland to release our LH and FSH. So LH comes around first. LH comes around first to act on the external cells, which is the thecal cells. So within the thecal cells, it's stimulated because the pathway for synthesis of androgen actually begins from cholesterol because it's a lipid hormone. So cholesterol is the one that starts it. You guys picture that diagram when they were talking about the what's it called? What's all these
Congenital adrenal
yeah,
hyperplasia.
congenital adrenal hypertrophy. Sorry, I'm even these are our 24 alpha reductase, 11 beta hydroxylase deficiency, so congenital adrenal hyperplasia. So, you know, they undergo the same pathway. Cholesterol is the starting molecule acted upon by cholesterol desmolase, produce, our pregnenolone that further goes down, differentiating to what we want. Some go down towards the mineralocorticoid and the glucocorticoid axis, while some goes linearly, towards the androgen pathway. So cholesterol will be acted upon and it will secrete the first intermediate molecule, androstenedione, within the thecal internal cell of the follicle of the ovary. So they produce androstenedione. So it is this androstenedione that can now go into the testosterone or dehydroepiandrosterone. So anyone they want to go to. So yeah, so that is that about the androstenedione. So androstenedione majorly goes into testosterone, then testosterone can take it to dehydrotestosterone. Now, granulosa cell, in the granulosa cell, aldosterone, this androstenedione that is produced enters the granulosa cell, and it's important to know that aromatase acts on the granulosa cell, just like aromatase also acts on androstenedione in the Sertoli cell. It takes it to histrone. Histrone is the first intermediate molecule that it goes to, and from the histrone it can be converted to estradiol, and that recycle can happen like that, but that one is actually under the influence of FSH. So LH comes in, stimulates production of androgen in form of androstenedione in the thecal internal cell. FSH comes in, stimulates the granulosa cell to utilize the androstenedione that the thecal internal cell has produced, converting it to the estrogen that the body actually needs, because this is a female. What they need majorly is estrogen. But the first estrogen that is produced is estrone. So it's the estrone that can now be converted to estradiol. Our estradiol predominantly comes from the placenta. So that is that about the cells within the follicles. Then we move next to progesterone. So progesterone, like we always remember, we must always remember placenta, because placenta can secrete both progesterone and estrogen. So it is secreting progesterone here. And of course, before fertilization, there's something that is, nourishing the endometrium. That is corpus luteum. So corpus luteum can produce progesterone. The adrenal cortex can produce progesterone, and the testes can produce. We can know this thing, but I don't think they can actually test it like that. So just know that these are the structures that can produce progesterone. I don't think they are high yield stuff, but the function of progesterone are high yield. Then again, the drug that can affect progesterone is high yield. You will see it in your exam. I'm sure of that. One of you guys will see it. So especially mifepristone, You have to know the mechanism of action of mifepristone and what it does. So mifepristone is an anti-progesterone that we can use it, and we can use it as an abortion drug. So if you want to abort a pregnancy, you don't want to keep that pregnancy alive anymore, just inhibit progesterone supply by giving mifepristone. Baby dies immediately. So of course, we know that progesterone is produced during the luteal phase um, of the ovarian cycle, and it prepares the uterus for receiving the developing blastocyst. So, what are the three major functions that I want you to know? Number one, it stimulates the endometrial glandular secretion and spiral artery development, as I said initially. So it stimulates the glands within the endometrium to secrete mucus, and it causes enlargement of the spiral arteries so that they can be well vascularized to nourish that fetus, with placenta formation. Because these are the cells, these are the areas that your chorionic villi will grow into. So they need to be able to receive adequate amount of blood. Then the next thing is this person is now pregnant. Now, I want to ensure that pregnancy doesn't happen again. Hmm. How can I achieve that? By making the cervical mucus to be thickened. So this is one of the bases of giving combined oral contraceptive that contains both estrogen and progesterone. So that is the way the progesterone component acts. The progesterone component will act by thickening the cervical mucus, making it difficult for sperm to ascend into the uterus to fertilize the ovum. At the same time, the estrogen component of our COCP is there to cause that feedback inhibition on FSH and LH so that they are not released again. So there won't be, you know, ovulation and the likes. So that is one of the mechanisms by which your OCPs are working. So progesterone stimulates glandular secretion and tortuosity of the spiral artery. It thickens the cervical mucus to prevent sperm ascension. It inhibits endometrial hyperplasia, just antagonizing the action of estrogen. So progesterone, if you are giving someone progesterone, you can't expect that person to develop endometrial malignancy because it's not undergoing endometrial hyperplasia. But if you are feeding that person with too much estrogen, the endometrium can undergo hyperplasia, which can progress to malignancy. Progesterone inhibits estrogen. That is why it inhibits endometrial hyperplasia. Another vital thing to know about progesterone is that it is a major hormone. This one, I've seen it in the question. We have to know it. Many people will just go for LH. That's what they think, LH. It is progesterone that is involved in increasing the basal body temperature immediately after ovulation. It acts on the hypothalamus to increase the hypothalamic set point for temperature, and your body will think that you are in a very cold environment, that you have to work more to reach that hypothalamic set point. Just imagine that your body increases the hypothalamic set point to about from 37 to like 39. To your body, you are cold, so it will want to work more to increase the body temperature towards that 39. In the process, the body temperature is going to rise. That is what progesterone does. So it's responsible for increasing the basal body temperature few hours or few minutes or few days after ovulation. So it's a very strong marker for ovulation. Once you see that you're measuring your temperature and it is about 0.5 degrees Celsius or 1 degree Celsius more than before, that means ovulation has happened. And of course, I've said it initially that it down regulates estrogen receptor expression, and it also has a feedback effect on LH and FSH, just like our estrogen. So, what are the effects of progesterone in pregnancy? Of course, I've mentioned it. It helps to maintain the endometrial lining, so that it can provide a very, very good fertile environment for the fetus to grow. So, at the same time, it also inhibits one of the actions of estrogen. I've mentioned that estrogen has an increased, action on the myometrium, allowing the myometrium to contract so that you can expel the fetus. But progesterone has a calming effect on the myometrium. It inhibits myometrium excitability. The third function of progesterone on the fetus is to
So you said myometrial what excitation, have you?
excitability. Yeah. So I know the last one is now inhibiting prolactin, um, um, function just like estrogen. Yeah, so this is it. I'm sorry about that. So yeah, so it's those are the three actions of progesterone on pregnancy. It maintains the endometrial lining, which we have said, when the person is pregnant, to allow so that is why if you give that person anti-progesterone, you lose that pregnancy. It inhibits myometrial excitability so that you can reduce the strength of contraction. And if someone wants to, if there's a preterm contraction or something, you can give the person a progesterone containing drug, to calm that uterine contraction. Then, just like estrogen, it also suppresses the action of prolactin on the breast. Just like I've mentioned too, fall in estrogen and progesterone after delivery disinhibit prolactin, so that prolactin can now act. So that inhibitory effect is lost. Prolactin can now act and stimulate lactation. Okay. So yeah, so let us go to the phase of oogenesis. What happens during oogenesis? I'm sure that we have understood what happens during spermatogenesis. The same thing happens here in oogenesis. There are just some little details that separate them. So, of course, the primordial germ cells that are derived from our yolk sac in the early uh, embryonic period, the ogonium, ogonium or something, ogonium, sorry about my pronunciation, ogonium. It is diploid, just like the spermatogonium. It is diploid, it contains two N, two C, two copies of the chromosome, maternal and paternal, and this copy of that chromosome, let's say chromosome 1, is made up of two sister chromatids. So this one is quite different from what happens in spermatogenesis, because in spermatogenesis, I told us that one happens or begins at puberty. Here, you don't wait for puberty. So immediately during the embryonic period, all these ogonium, they are already dividing. So they undergo DNA replication. You guys remember that here, if this was spermatogenesis, you have your blood testis barrier here, but there's nothing like blood testis barrier here. So they are just playing within the ovaries. So it undergoes DNA replication, just like we know, and it forms the primary oocyte, which is a diploid structure, because I've said it, in DNA replication you are just duplicating the sister chromatids. So instead of you having two sister chromatids, now you have four sister chromatids. And of course, the paternal and the maternal copies are still retained. So the configuration is 96 sister chromatids. Now, what happens? The primary oocyte now begins the process of meiosis, which is where division into two cells start happening. Now, this meiosis is important for us to know that it happens during the fetal period. So that's like beyond the 8th week of gestation. So when the fetus has now started forming, that's when meiosis 1 commences. Now, during the replication, from this ogonium to primary oocyte, you will have had a lot of replication up to like as high as 7 million primary oocyte will have been formed. A lot of them will be formed. So all the oocyte that the lady is going to have in her life will have been formed. So everything will just be used one by one, till everything comes down at menopause. So it's not like you are forming new. No, the everything that is going to constitute that pool has been formed already during the embryonic period. So you have like about 5 to 7 million oocyte that is just there. So those oocytes will now keep differentiating into the secondary oocyte, then to the ovum. So when they get exhausted, menopause setting. So what happens, during meiosis one? During meiosis one, you have the primary oocyte separating into the two secondary oocytes. But sorry, one secondary oocyte and one polar body. One secondary oocyte and one polar. But it's important for us to know that this process is actually arrested at prophase 1. Please, guys, am I too fast? Hello?
We can see you.
Okay. So it is arrested at prophase 1 until ovulation. So once this individual gets to puberty and the person can now undergo menstruation and all those things, so that is when you now have eventual formation of a secondary oocyte. So at ovulation, that is when you have completion of the meiotic 1 phase, which is division into a secondary oocyte with 46 sister chromatids and a polar body that degenerates. So without ovulation, you cannot have release of secondary oocyte. So that means that what is actually released at ovulation is secondary oocyte and not ovum. Not ovum, but secondary oocyte. That is what is released at ovulation. Now, the next thing after ovulation is okay for development to grow. So that means that the duration between secondary oocyte and ovum is not actually very how do I put it? Is not quite far apart, provided that fertilization can happen as soon as possible. So once fertilization happens, your oocyte becomes the ovum. So as development progresses, the secondary oocyte, tries to develop into the ovum. But during the process of undergoing the division, which is the prophase, the metaphase, the uh, the anaphase, the telophase, it gets arrested in metaphase. So we call it metaphase 2 because this is meiosis 2. It gets arrested in metaphase 2. It will now be waiting for the sperm to now come. So once it gets fertilized, bam, it will immediately mature into um, one polar body and an ovum with 23 chromosomes. So it is this 23 single chromosome ovum that will now merge with the spermatozoa to form a zygote with 46 chromosomes. All the polar bodies that are formed degenerate. Guys, I hope you can explain the 2N, 2C, 2N, 4C, 1N, 2C, and the 1N, 1C. I hope we can explain it just using our knowledge of what's it called? Our knowledge of what we have learned in
Yes.
okay. So that should
Haploid,
be
diploid, haploid, haploid.
mm-hmm,
One N, 2C
mm-hmm,
goes to 4N, 2N, 4C
okay.
goes to 2N, 2C,
No, no,
and
no,
then 1N, 1C.
no. I've said it, I've given you a code. Once you start meiosis, you know that division is already happening, like splitting into two. So
Yes.
automatically it won't be two hen again because it's going to
Sorry,
split
to be
into
1N2C. Sorry, 1N2C meiosis 1.
one hen.
1N2C meiosis 1.
Hmm.
And then by meiosis 2, it has become 1N1C.
All right.
Yeah.
So now,
Dr. Babali.
yes, Dr. Francis.
So, yeah, so with what you were saying, so during meiosis one, that's when you have the, what is over here? The oocyte being arrested, right, until ovulation,
Mm-hmm,
right?
mm-hmm,
So then it's during that a particular cycle or something that you have the oocyte moving into. So then when it's time for that egg to be released, then it enters meiosis 2. So it undergoes prophase, then it gets arrested at metaphase.
okay. Yes.
Right. So now I'm just clarifying,
Yes,
meaning
yes.
that if the egg is not fertilized,
Mm-hmm.
the one that is shared together with the endometrial lining is what is in metaphase 2, the one that was arrested. Right.
Exactly. So that means that
Okay.
what is slowed off with endometrium is actually secondary oocyte. It will not get to the ovum. It will not.
So
Unless
it's a secondary
fertilization.
oocyte.
Yes, it's
Okay.
secondary oocyte. Yes,
Okay.
you are very
So it
correct.
only becomes an ovum when it is fertilized.
Fertilized. That is it. That is it. Very
Oh,
important.
okay.
Very
Okay.
important. Mm-hmm.
All right. Thank you.
Yeah, you're welcome. So, what happens at ovulation? I don't know why they are putting ovulation here, but we just keep learning it the way it is arranged so that we don't miss out anything. So, of course, we know process of ovulation is just I've mentioned it that the way the oocyte is that it is surrounded by follicular cells. So it's just like a small structure that is surrounded by follicular cells. And these follicular cells consist of the theca cells as well as the outer theca cells and the inner granulosal cells. So within inside them you have the ovum, or anything, the oocyte, depending on the stage. It can be ogonium, it can be primary oocyte, it can be secondary oocyte or ovum, depending on the stage. So now I've mentioned it that during the ovarian cycle we have, although I'm still going to talk about it too when we get there, but just to mention it, we initially have an increase in estrogen because when a lady reaches puberty and the person is undergoing, the menstrual cycle, there is initial release of GnRH in the pulsatile manner, which is the manner that is necessary to trigger release of LH and FSH from the anterior pituitary gland. So, due to that pulsatile GnRH release at puberty, there is release of LH and FSH. The FSH acts on the follicles within the ovaries. The follicular cells are containing all the oogonia and all those things within the ovaries and stimulate the proliferation of some of them, quite a number of them. So they undergo proliferation and maturation. So as they mature, they begin to differentiate into different types. But the final matured form of the follicle is called the antral or the Graafian follicle. Now, as these follicles too are maturing, because they contain some cells, which is the theca internal cell and the granular cell. Granular cell is also releasing estrogen that also helps with the maturation of the follicle, the follicles of the
Mr.
ovary.
Babadi, I've lost you. I'm lost. Sorry. I'm not even sure where you are now. Are you talking about ovulation? Like,
Yeah.
I mean, so this is the point at which um oh, so this is not even, this is still pre-fertilization.
Yes, this is pre-fertilization. Definitely. It's still pre-fertilization.
Okay, okay,
So,
okay.
you know that ovulation will have happened here, Dr. Francois. Ovulation is
Yeah.
marking the completion of meiosis 1. So,
Yeah.
once ovulation happens, there's completion of meiosis 1 to form the secondary oocyte. So, you'll be at the level of secondary oocyte. So, if the sperm now comes in, it's not going to cause eventual, because before the sperm comes in, this secondary oocyte will have started meiosis 2, but it will have
Meiosis
completed
two.
it. So
Right,
we have
right.
arrested at metaphase. So when sperms now comes in, that's when they now rush the other phases to quickly divide
Mm-hmm.
um an ovum and a polar body. Mhm. So
Okay.
the ovum now gets joined with the sperm to now form um the zygote. So I'm
Right.
just talking about what happens before. Maybe I should just keep it here and go to this place, because I don't know the reason why they said, because it's not organized. Just put ovulation here when you're actually talking about the menstrual cycle proper here. So maybe I'll just talk about this and mention ovulation there. So the menstrual cycle is just talking about the regular cyclic changes that occurs within the female reproductive tract, you know, in preparation for fertilization and pregnancy. So it occurs in two major sites of the female reproductive system. You are looking at the uterus and you are looking at the ovaries, and they occur simultaneously. So what is happening in one area is affecting what is happening in another area. What's happening in the ovaries especially is what is driving the changes in the uterus. So they are categorized into three phases, but the middle one that is unifying them is ovulation. So ovulation is here. um Ovulation in the ovaries, ovulation. The starting one for the ovarian cycle is the follicular. Why? As the follicular phase is happening in the ovaries, what is happening in the uterus is what? Proliferation, proliferative phase, proliferative. Then at the mid-cycle you have ovulation. Then subsequently after ovulation, what happens in the ovarian cycle is the luteal phase, that is formation of the corpus luteum, formation of the corpus luteum. At the luteal phase, the corresponding phase in the uterus is what? The secretory phase. Please, luteal phase is happening with secretory phase, but secretory phase is that of the uterus. Luteal phase is that of the ovary. So let's start again. So if this individual reaches puberty and there's release of GnRH from the hypothalamus, you have enough GnRH being pulsatilely released, and it further drives the secretion of LH and FSH from the anterior pituitary gland, which now starts acting. So your FSH and the LH comes to act, the FSH rather.
Sorry,
You can
sorry. What's stimulating the release of GnRH?
So at puberty, that's what marks, once the patient reaches puberty. Do you understand, Dr. Olushola? Once the patient, if it's a lady, reaches the age of 8, puberty, begins. That's just physiologic.
Okay.
Yeah. So you have the pulsatile release of GnRH at that time, and it acts on the anterior pituitary gland to release FSH and LH. So we can start appreciating the changes that happen. So you can see here at the follicular phase of the ovaries, there is the release of FSH more than LH, because it's actually what drives that follicular phase. From the name, follicle stimulating hormone. So they start stimulating the primordial follicles in the ovaries. So and they start developing. They undergo different stages of development. Your level of LH2 is there, but it's not as high as FSH. They undergo development. So these are the ovarian changes. So the follicles undergo different development until they are finally matured. And as they are developing, their cells too are developing. The granulosa cells there are able to secrete estrogen from the activity of the thecal cells, because you know that thecal cells are the one that produce androstenedione that will now be converted by aromatase in the granulosa cell to our estrogens. So the estrogen is now also going to assist with the follicular development and also come down to the uterus to cause endometrial hyperplasia. So you have increase in the amount of, so this is where it's starting. You know, you can see that as the follicles are developing, you are having uh, a simultaneous rise in the level of estrogen. It's rising. It means that estrogen is coming from the ovaries and is also coming from this follicle. So they are coming from those two sources, so the level of estrogen is rising and is acting on the uterus to stimulate endometrial hyperplasia. So you have an increase in the amount of endometrial cell. So with time, as the estrogen level is rising, it gets to a point that it's, you know, because estrogen normally inhibits the level of FSH and LH. That's why you can't have LH increasing at a very, very high level. It can't get high because this estrogen will be there to bring it down. That's why you are seeing as it's increasing like this. You know, estrogen too is increasing because development of these guys will produce estrogen. But as the estrogen is now increasing more, it's now bringing the FSH down due to the inhibition that it has, as well as the LH. It's bringing both of them down. But with time, about 12 to 24 hours prior to ovulation, you know, the level of estrogen peaks to a very high level and causes LH surge. So it just stimulates the anterior pituitary gland to release LH. So once there is that LH surge, this Graafian follicle that's already matured ruptures to release its content. And the content is going to be the secondary oocyte. So it's going to release its content, which is the secondary oocyte. So that means that the follicular cells that are surrounding the secondary oocyte are now free. They contain the thecal cells and the granulosa cells. So they are going to change into what we call the corpus luteum. So granulosa cells will continue to secrete estrogen, while and estrogen, yeah. So while our thecal cell is going to continue to secrete testosterone and progesterone. So now, immediately after you have this rupture, the level of progesterone more is increased because that is, the major function of corpus luteum. Although it secretes both estrogen and progesterone, but the level of progesterone is more. The secretion of progesterone is more than estrogen. So you can see that estrogen that is initially down, you know, is more following ovulation. So you have an increase in the level of progesterone. So at this point, you are going to have a rise in the basal body temperature. So that is why you can, confidently say that estrogen has increased because progesterone has risen, which has caused an increase in the basal body temperature. So what I just want to mention here is that the duration of, the starting of the follicular phase to ovulation is not constant. It can be 14, it can be 13, depending on the duration of the menstrual cycle of that individual. But what is always constant for everybody is the duration of the luteal phase. That is the point from ovulation to the beginning of menstruation, to the first day of menstruation. It is always 14 days. You must always remember that fact. It is always 14 days. So when you have the ovaries, rupturing and they release the, sorry, I said ovary, the follicle rupturing to release the content, which is the secondary oocyte. The remaining cells, follicular cells, differentiate into the corpus luteum that begins to secrete progesterone. So this progesterone, what's the effect of progesterone? The effect of progesterone is to now come to the endometrium and increase the tortuosity of the spiral arteries. So you can see that the spiral arteries are now lengthening. So they are now becoming more, dense and, providing more blood supply to that side. And also the glands are also more secretory. So they are secreting a lot of hormones. So of course, you know that the corpus luteum release both estrogen and progesterone, but just that progesterone is more. And of course, those two guys will keep the level of LH and FSH in check. That is why during the luteal phase, there's a reduction in the level of LH back to normal level and reduction in FSH. But in ovulation, there's a surge in LH. There's also a rise in FSH. You should know that. There's a rise in FSH too, but it's not as much as LH because LH is actually the one that is driving, that follicular rupture. So I've explained what happened in ovulation. The blood loss that occurs following, you know, rupture of the follicle can irritate the underlying peritoneum, which usually, if it occurs in the right side of the ovaries, if that's where the release takes place, it can collect within the lower peritoneum and irritate the parietal peritoneum there, causing a pain that we call meteshmals, which is one of the differentials of acute appendicitis. So that's the stuff that was mentioned here. I think that's just summary of what was said here. So peritoneal irritation following normal bleeding due to follicular rupture can cause meteshmals, which is a pain that's usually unilateral and mild, because you know that most of the time you only have ovulation happening in one fallopian tube, one ovary. It's not both. So if you are forming it, releasing it at both sides, that means the person is trying to form a twins, and you know that majority of people release one egg, not two. So that is that. So now, so when that happens, the corpus luteum, needs to be protected. You know, it needs to keep functioning so that you can maintain that endometrium in the luteal phase. So that is when uh, ATG now comes in. So if there is fertilization, if maybe after 12 days or 14 days, so okay, no, let me say it well. So now you have follicular rupture and it has differentiated into the corpus luteum. It is secreting progesterone. But after 12 to 14 days, this corpus luteum degenerates into corpus albicans. So when it degenerates into corpus albicans, there's no progesterone support again. Mm. So when there's no progesterone support again, the endometrium slough off. So it's being lost outside as and being shared away as the menses. So at this point, that is where menses begin. So you can see here, there's a sharing of the endometrium. So menses begin at this point. Always remember that this point to this point is 14 days. It's 14 days. But around the 12 to 14, that's where you have your corpus luteum starting to degenerate, you know, into corpus albicans. Now, that is if there's no fertilization. If there's fertilization, which will have happened max 1 day after ovulation, if there's no sperm available in the fallopian tube or in the uterus, 1 day, within 1 day after ovulation, fertilization cannot happen. So the limiting factor is actually the sperm. So if sperm is there, yes, the ovaries are always ready every month to release so that the sperm can see something to combine to. But if there's no sperm there, within 24 hours, you know, that secondary oocyte dies and it doesn't eventually differentiate into the ovum. But if there's a sperm around within 24 hours and is able to fertilize that secondary oocyte, making the completion of meiosis 2 to allow formation of the ovum and eventual combination of the sperm and the ovum to form zygote, with eventual implantation of the zygote. So that means that after fertilization, within this period now of this endometrial building that is happening, because it has not shed, the zygote is already developing. I told you guys that this takes like 14 days. And you know that by the end of the second week, by the end of the first week, day 6, it will have implanted here. It will have implanted at day 6, somewhere here. So if it implant by day 6, around day 7 onward, your syncytial fibroblasts is already being formed, you know, due to the establishment of the placental connection. So your syncytiophoblasts, which is a component of your trophoblast, secrete HCG, which is your human chorionic gonadotrophin, that allows differentiation of this corpus luteum to corpus luteum of pregnancy. So that corpus luteum of pregnancy continues to fire progesterone beyond, you know, the 12th or 14th day that this corpus luteum degenerates. So it doesn't degenerate, it doesn't differentiate to corpus albicans. It rather goes to the corpus luteum of pregnancy and continues to release progesterone until the placenta is matured enough to take over that function. So that is why you don't have shedding when there's fertilization. So guys, did you get it, or I need to clarify some areas? Hello, anybody with any question?
No, I think I get it.
Okay. So yeah.
So, is there a significance to the fact that the luteal phase is fixed? There should
Uh
be.
uh Maybe if they want to do some calculations, but
Mm,
those are deep O and G stuffs. I think
those that are.
it has significance actually. I think the significance is if you want to calculate the gestational age. So if you know the okay, let's look at it, because there's something called the embryonic age and there's gestational age. So embryonic age is uh the the age of the fetus starting your count from the point of fertilization. The gestational age is starting your count from the first day of the menstrual period, first day of the last menstrual period. That is this day where the menses starts happening. And you know that this day to ovulation is 14 days. That's constant. So if you know the embryonic age, which will have happened somewhere here, you guys know that embryonic age will have started counting from here. I don't know if you guys can picture what I'm saying. Embryonic
Yeah,
embryonic age is a point from fertilization. So
yeah.
if you want to know the embryonic age, you can actually know it. Now, if you know that this is the day where the person starts menstruated last, this is the day
That will be for the last cycle, Abby.
for the last cycle. This is the day.
Not this one. Okay.
So you know that of course when the person is pregnant, the fertilize this all stuff that we are talking about will not happen. So there's nothing to work with there. So if this is the day that the person last menstruated, if you want to know the embryonic age, what you just do is that you just remove 2 weeks from that day.
No, actually, it should be. Yeah, I get what
Add.
you're saying, but I think that what you have to do is it should go to the previous menstruation page. Do you get it? Because once fertilization occurs, the person will not menstruate.
Mm-hmm.
So technically, the embryonic age will actually be um might be less than the estimated gestational age.
Yes, you
Do you
are
get what
correct.
I'm saying?
That is why I'm saying
Exactly.
yes. So the gestational age is actually more than the embryonic age because you are adding 2 weeks to the embryonic age for the gestational age.
Yeah, yeah, exactly.
So you remove 2 weeks, which is the duration of the luteal phase. So from it, that's just the significance that I can think of.
Yeah, I did not get it though, but it's okay.
Dr. Francois, do you want to shed more light? Let me hear from Dr. Francois.
Dr. Zuliet, are you awake?
Yes, I'm awake. I'm with you.
Okay. So basically what we are saying is that so there are two phases of the ovarian cycle, right? There's the follicular phase and then there's the luteal phase, right? And you know
Mm-hmm.
that the entire phase of the menstrual cycle varies from woman to woman. So some
Mm-hmm.
people might have as low as 21 days, some people 35 days.
Mm-hmm.
But um of of the entire cycle, one phase is fixed and the other varies. So the fixed phase is the luteal phase, and it is a fixed 14 days from the
Mm-hmm.
time of ovulation to the first day of menstruation. Okay, do you get that so far?
Yeah.
right? And typically when a woman conceives and we are trying to estimate the gestational age, we use the last menstrual period,
Mm-hmm.
right? Now, what we are saying is that possibly the significance of knowing that the luteal phase is fixed is that we can have, for calculating the age of a pregnancy, there's what they call the estimated gestational age, which is from the last menstrual period, and then there's the
Mm-hmm.
embryonic age, which
Okay.
which comes from ovulation. Because I mean, strictly speaking, we know that obviously it is after fertilization occurs that you have the zygote being formed, then the embryo, then the fetus, right?
Uh-huh. Uh-huh.
So if you use embryonic age, you're able to tell exactly when ovulation was. Then you know the actual age of the pregnancy. As for the last menstrual period, it's just an estimation. Do you get?
Okay.
So
Okay.
if you know you have an idea of the cycle length, and you are able to tell the um, the time from the last menstrual period to that person's possible date of ovulation, you just have to subtract about 2 weeks, because we are saying that the luteal phase is fixed. Do you understand what we are saying? In order to be able to get the person's the embryonic age of
Embryonic
the,
age.
yeah. Do you get?
Are
Yeah,
are you
I kind
are
of
you
get the
subtracting me?
explanation, but the interpretation basically, I don't know, maybe
You're
my
not
head,
sure if of the significance.
yeah, like
Yeah.
my head did not carry it.
Right. But I
Yes.
think another thing that occurred to me, Dr. Babale, even when I asked the question, was
Mhm.
sometimes, for people who are trying to achieve conception, when people are dealing with, like, some infertility issues or something, I think
Okay.
the luteal phase tends to be significant. I think there's
Okay.
something like that. Yeah, I've forgotten.
But
Maybe we all just have to verify.
Dr. Francois,
Yes, Dr. Lushola.
my query is that fine, we know the luteal phase, Abby,
Mm-hmm.
which is 2 weeks, right?
Mm-hmm.
Mhm.
So follicular phase is the one that varies, right?
Mm-hmm. Mm-hmm.
So and we said the ages from the first day of last menses.
Mm-hmm.
So I'm interpreting it to be last menses of your last cycle.
Mhm.
Mm-hmm.
So I'm still going way back.
Mm-hmm.
So that means my calculation now includes the follicular phase of this present one that led to
Mm-hmm.
pregnancy.
Mm-hmm.
So and we said follicular phase it varies.
Mm-hmm.
So how do we now know the number of days to
Me,
add?
I'm thinking the reason. See, guys,
Yeah.
you know that
Right.
what me I'm thinking is that if I'm subtracting 14 weeks, I'm not actually considering the follicular phase because this 14 week is between here to here. This is
14
14 days.
days.
This is the 2 weeks. We are not considering
Okay, I
because
get
this
what
one is
he's saying.
that's
Right.
not
Dr. Babale, okay, I don't want us to drag this because I don't know how relevant it is. But Dr. Babale, basically what Dr. Odushola is saying is that
mm-hmm.
the last menstrual period, right,
Okay.
would have occurred before ovulation.
Before ovulation.
Do you get it? And before ovulation, you have the follicular phase, and that's the one that we are saying varies. So how can you be so sure what the number of days is? But what I also think is that depending on
Okay.
the person's history, if you have the person has a general idea of their menstrual cycle,
Okay.
you can always estimate or
Estimate
something.
it.
Shola, do you get?
Maybe we'll
Yeah, but
just check it off and
yeah,
I'll get back to it because me I'm not an ONG expert, but that's what I used to know. That's what I used to know.
yeah, right.
All right. So yeah, so abnormal uterine
Kudos to
bleeding.
you people. The Lord is your guidance. Let's move.
Hello, who is that Dr. Zuliat? So
Thank you.
yes, let's move to abnormal uterine bleeding. So uterine bleeding now they've discarded some terminologies that we used to know. The menorrhagia, the metrorrhagial, the polymenorrhea, all of them have been discarded. So the way they define abnormal uterine bleeding now is any bleeding or deviation from normal menstruation in terms of the volume, in terms of the duration, in terms of frequency, the regularity. So regularity is just the same thing as intermenstrual bleeding of a teen. So maybe if the normal volume of menses should be 50 mils. So if someone is bleeding as much as 100 mils or the person is seeing clots, you can say that that is abnormal uterine bleeding. Um, Menstruation that is, of deviation from normal duration. If the normal duration of menses should be averagely, let's say 28 days, like between like maybe 25 to like 35 days. I don't what's the normal range for menstruation?
Duration of menses. Ah,
Yeah. No, no,
Are you
no.
that's too
talking about the
long.
length
You
of
are
the
saying the
Are you
menstrual
talking
cycle?
about the
cycle.
cycle?
You are saying cycle. I'm not saying menses. Menstrual cycle.
Ah.
21 to
Sorry.
35.
Yeah, yeah, yeah.
Uh-huh.
So, but what I'm actually talking about here, I made a mistake. Is the duration of the bleeding, which is the menses, that 3 to 5 days. So it should normally be 3 to 5 days. So
Some 7 days.
some 7 days, Abby.
No, it's 3 to 5 days on the average, Dr. Zuliat.
Maybe some people have,
Yeah,
maybe
then.
Dr. Zulia know people that have bleeding.
No, there are actually
Ah,
people that have
that
seven
could have
days.
been for
Jokes
seven
apart,
days.
there are
Now.
7 days, but
Okay.
on the average, is 3 to 5 days on the
Okay.
average.
Dr. Toby, you're welcome back.
Okay.
Oh, you've missed me, right? How did you?
So in terms of the duration of bleeding, 3 to 7. So anything beyond 7, anything less than 3, abnormal. Then the frequency of occurrence of the menstrual cycle. So maybe it's supposed to come every so that's what I'm trying to say, like maybe 25 to like 35. I'm not actually sure of the, but I used to know that averagely it should be like 28 days. So for everybody. So let's say that it's coming for somebody maybe fast, it's coming every 20 days, or it's coming too delayed, like it's coming every 40 days. That's an alteration in the frequency of the menstrual cycle. So that's abnormal. Then the regularity of the sorry guys. That is not what I should say, because what we're actually considering here is the bleeding, not the whole cycle. I don't know if you guys get what I'm saying. So
Yeah, we hear you.
yeah, so the frequency of the bleeding, maybe you are supposed to see the bleeding. Okay, yeah, I think it's the same thing. I'm not really very good with this stuff, but I think it's the same thing as what I'm saying. So the
So
regularity.
I think over here the frequency is probably referring to the cycle,
Mm-hmm.
because then when you come down, the next part, the one that talks about intermenstrual bleeding, that one talks about like
The regularity
um
in between.
I in between, yeah.
Yes. So if you are supposed to you have menstruation now, because you're actually counting from the first day of the previous cycle to the first day of the next cycle. That's the duration of the menstrual cycle. So let's say that someone has started menses now, and is supposed to start another one in 28 days. That's how it should be. If that person is now seeing bleeding again in between that 28 days, so that is, intermenstrual bleeding. So it's a deviation from normal, bleeding situation. So I don't know if you guys get what I'm saying, or I should come again. Maybe I should just come again with what I'm saying. So in terms of the volume, we get that like averagely 50 mils. So anything below 50 mils, more than 50 mils, or you are saying clot, so deviation in the volume. Duration of the bleeding, 3 to 7 days normally. So if you are bleeding more than 7 days, bleeding less than 3 days, problem. The frequency of the menstruation. So if maybe the person is usually seeing his menses every 28 days. So if the person is now seeing it every, if the person is seeing it every like 20 days or 23 days, so it's now coming earlier. So that's, um higher frequency. Yeah. So then the regularity. So if you are supposed to be seeing it every 28 days, 28, you are now seeing 23, next month 25, another month 20. So it's becoming irregular. So that is that. Then, so what are the causes for abnormal menstrual bleeding? They are divided into the structural and the non-structural. So the structural includes things like polyps, endometrial polyps, because if someone has a polyps, because normally the way you can, stop endometrial uterine bleeding is to ensure adequate contraction of the endometrium. So if someone has a polyps cannot achieve adequate contraction of the uterus, so there will be increased bleeding in that kind of person. Someone that has adenomyosis means the experience of an ectopic endometrial tissue outside the endometrium. So the person is having the endometrial tissue specifically within the myometrium, which is just next to the endometrium. So that kind of person will have more endometrial tissue being present. So there's tendency of having more bleeding. So at the same time, the contraction of that kind of endometrial tissue will not be as adequate as the one that is within the endometrium. So the person can be predisposed to having abnormal urethral bleeding due to the high volume of endometrial tissue that is present. And of course, someone that has adenomyosis, they usually have a bulgy uterus. The uterus becomes enlarged because of the deposition of these endometrial tissues that are there. Then leiomyoma, that is benign tumor of the smooth muscle of the endometrium. Of course, it has so many pathophysiology for the abnormal uterine bleeding, but commonly it's just that the size, and the surface area occupied by the muscle would prevent adequate contraction of the endometrium, to arrest the bleeding. So that's one of the reasons why someone that has myoma can have abnormal uterine bleeding, which is excessive. And of course, someone that has endometrial hyperplasia or malignancy, there's abundant endometrial tissue, so there's high bleeding more than usual. Then the non-structural ones like the coagulopathy, of course, in coagulopathy, you cannot even achieve normal coagulation, so there'll be bleeding everywhere. Then the ovulatory problems. Ovulatory problem usually occurs people that have an ovulatory cycles. They're undergoing the menstrual cycle without ovulation. For example, people that have thyroid issues, you know, can have an ovulatory cycle. People that are obese, because these people will have increased production of estrogen. People that are obese, they have adipose tissue that is abundant. The adipose tissue is releasing a lot of estrogen. So, you know, and the person is not able to achieve ovulation to release, um, the follicular cells to form corpus luteum. So that means there's no progesterone source in that kind of person. And I've said it initially that what estrogen does is just to ensure proliferation of the endometrium. So the endometrium will just keep proliferating, and with time they will come down. So the bleeding is usually irregular because you can't predict, when it's going to come and when it's going. So they'll just keep proliferating, and when it gets to a point, because of the unopposed estrogen stimulation, just keep proliferating, and with time they will come down and shed. So, and that is when you see the bleeding. So it's usually irregular in people that know ovulatory cycle. And endometrial causes. So if there's any local factor affecting the endometrium, maybe there's an infection there, maybe uh uh okay, yeah. So that's one of the things I can think of. An infection within the endometrium can cause abnormal uterine bleeding. Iatrogenic, maybe the person is using the medication, or the person has an intrauterine device that is implanted in the endometrium. It can also affect endometrial bleeding due to the same contraction issue. Someone that has copper UCD cannot contract very well, cannot arrest, cannot constrict the spiral arteries to prevent bleeding. So the bleeding is usually much in people that are using IUCD, or people that are using drug that can affect the coagulation pathway. So it can also, be iatrogenic. They're not yet classified. For example, maybe people that have arteriovenous malformation in the ovary, in the endometrium. So there's abnormal bleeding in them too. So that's one of the causes that is classified under the not yet classified causes for abnormal uterine bleeding. So the code is PAM clean. So PAM, P for the polyps, A for the adenomyosis, L for leiomyoma, M for malignancy and hyperplasia, C for coagulopathy, O for the anovulatory cycle that I mentioned, maybe someone that has achieved menopause, because people that have menopause are, they are no longer ovulating. So the unopposed estrogen effect from maybe the one that are coming from the adipose tissue, can explain abnormal proliferation of the uterus. We can now shed irregularly. Endometrial, this endometrial, things of things like endometriosis. I can put it under endometrial. Endometriosis as a cause of abnormal urethral bleeding. Endometriosis is just similar to adenomyosis. It's also presence of the endometrial tissue outside the normal endometrium. So you are finding it somewhere. Maybe you are finding in the bladder, in the retroperitoneum, in the peritoneum, in the ovaries, the like. But when you see endometrial tissue specifically within the myometrium, that's when you call it adenomyosis. So both of them will actually have similar presentation: pelvic pain, dyspareunia, dysmenorrhea, uh, excessive bleeding, and the like. So iatrogenic, which is a high, That's when you are using drug or IUCD, then not yet classified. Okay, so let's go to
Dr. Babali, sorry, what did you say about the coagulopathy?
so coagulopathy. Maybe if someone has a DIC now, or maybe uh anything affecting the coagulation one pathway. If this person has antiphospholipid syndrome, or the person has uremia from CKD, they can cause
Mm-hmm.
convulsant disease. Shey you get? Those things can cause.
Abnormal inflammation. Okay.
So pregnancy. Well, we've talked, a lot about pregnancy before. You guys know how it happens. Fertilization occurring at the ampulla region of the fallopian tube, and usually occur within 1 day of ovulation. So any sperm that is just coming after second day of ovulation is not going to meet anything. The secondary oocyte will have degenerated. And we know that immediately after fertilization, we form a blastocyst. The blastocyst implants in the endometrium, which is already being prepared by the corpus luteum secreting HCG, secreting progesterone. And the blastocyst implant on the sixth day and started forming the cytotrophoblast and the cytotrophoblast. So in order to establish a placenta connection. And the cytotrophoblast has some hormonal function by secreting HCG. HCG is usually detected in the blood within the first week of fertilization. Why you can see it in urine within the second week. Very important for us to note that you see it early in the blood, then later, second week, you see it in the urine. HCG can work, as a luteinizing hormone, luteinizing the corpus luteum so that it can stimulate the thecal cells to produce progesterone because its structure is very similar to LH, to FSH, and TSH. We have to know that. It has two subunits, the alpha subunit and the beta subunit. HCG has beta subunit and alpha subunit. The alpha subunit of HCG is similar to the alpha subunit of TSH, is similar to the alpha subunit of FSH, is similar to the alpha subunit of LH. So that means that if you are trying to detect pregnancy by doing an assay for the alpha subunit of HCG, you are doing nothing because it can be influenced by the alpha subunit of LH, that of FSH, and that of TSH. So what is distinguishing is the beta subunit of HCG. The beta subunit of HCG is unique to HCG. That is what you specifically test for using all these homemade kits. The pregnancy and the blood. You test for the beta HCG level. And because of the fact that the alpha subunit of HCG is similar to the alpha subunit of LH, it can easily it can easily stimulate LH receptor. um in the corpus luteum so that they can become corpus luteum of pregnancy and they continue to secrete progesterone. Now, also worthy of note is that HCG can, uh, because of the fact that it shares the same alpha subunit with TSH, someone that has any condition that is associated with elevation of HCG can have hyperthyroidism symptoms. So someone that has maybe a cholangiocarcinoma now that is producing a lot of HCG, that HCG can act on TSH receptor and be driving thyroid hormone production. That is why hyperthyroidism can be one of the presentation of cholangiocarcinoma. Very important because cholangiocarcinoma is associated with high HCG level. So that's that about HCG. Then we talked about the embryonic or the developmental age, which is the time since fertilization. It is used in embryology. So when they say cardiac, you see, the heart beating at what week? Guys, when does the heart start beating?
Week 4.
Fourth week. So that's an embryonic age, time, period, embryonic period. So fourth week, the heart beat by fourth week of embryonic life, the limbs are already forming, you know, by end of fourth week, the neural tube has fused together and the like. So gestational age is the time, from the first day of the last menstrual period. So we use that one clinically to estimate the gestational age. So the gravidity just means the number of pregnancy that a woman has had. So if this woman has been pregnant like 10 times, the gravity is 10. Parity is the number of pregnancy that results in live birth. So this used to be different from what we used to know in my own center. So usually parity is said to be number of pregnancy that you carry above or beyond rather the age of viability. which is taken to be 28 weeks here. But according to USMLE, it is the number of pregnancy that result in live birth. So if you have not delivered that baby, you cannot count it as a parous experience. So parity is the number of pregnancy that result in live birth, while gravidity is the number of pregnancy that the person has had, regardless of what happens to that pregnancy. So there's a chart here. You can just learn it. It's not usually you don't really ask any question about it, but you guys can just learn it because you never can tell. So just showing the weeks of gestation on the x-axis and the hormonal level on the y-axis, and talking about the representation of four hormones: human placenta lactogen, no, five actually: human placenta lactogen, estrogen, prolactin, progesterone, and hcg. mm. So the one that doesn't actually last towards the end of gestation is hcg. So that one is very easy to recognize in the graph. So you know that hcg begins to be formed within maybe day 6, when you have formation of the syncytiophoblasts following implantation. Maybe like let's say first week, hcg starts rising, you know and it will have even be produced, from, yeah, so from the first week. And it act on the corpus luteum, causing the corpus luteum to differentiate to corpus luteum of pregnancy, so that it can continue the progesterone secretion. That is why you initially see it here that progesterone is the one that rises, at this time, more than the others, because it's coming from the corpus luteum, hcg at this time is coming from the placenta. It's not coming from corpus luteum. Don't be deceived though. So it's actually the syncytiophoblasts of the placenta that is secreting hcg at this region. So it continues like that until about 8 to 10 weeks. That's where it peaks. So this 8 week, this is around the 10th week, so it peaks, then drops. Mm? So it drops. Then around the 8 to 10 week, maybe like 11, 12th week, the placenta is already functioning there. So the placenta continues secretion of the ATG, and then it eventually drops. So that's the way ATG develops. So the corpus luteum, you know, the cytoplasm of the placenta, continue secretion of uh, ATG. It allows differentiation of corpus luteum to corpus luteum of pregnancy, then allows corpus luteum to continue secreting progesterone, peaks to about uh, peaks around 8 to 10th week, then the level subsequently drops. So the corpus luteum around the 10th week, you know, where ATG has already terminated, sorry, has started falling. Okay, now guys, let me say it well. This corpus luteum is the one that is driving secretion of progesterone before. But I said that the HCG from the syncytiophoblasts peaks at around 8 to 10 weeks. Then it subsequently drops, because the corpus luteum is now has to now go. So it drops. So around this time, that's where your corpus luteum starts disintegrating. Then your HCG level tapers down. So around this time, this is the highest time that you can get your progesterone. Then subsequently, progesterone secretion is being taken over by the placenta. So progesterone level, continues to be secreted by the placenta beyond from this point beyond. So not from the corpus luteum again. So this particular transition is actually talking about transition of secretion of estrogen and progesterone by the corpus luteum. So from here to here, um that is where your corpus luteum is actually the one in charge of your secretion of your progesterone and estrogen. So then this is where it peaks, then subsequently it falls. So from here, that is where your placenta starts, being in control of secretion of estrogen and placenta. Placenta has been in control of secretion of prolactin and human placenta lactogen right from onset. So your placenta is the one in control of that one. But the one that switches is the secretion of progesterone and estrogen between the placenta and the corpus luteum. So guys, I know I need to explain. Do you guys get it, or should I say it again? Hello guys.
Yeah, we're here.
Do you guys get it, or should I come again?
I think it's self-explanatory. Let me try and go over it so that we'll see whether we get
Okay.
it. So basically, we are looking at the hormones of pregnancy, right, and then the different weeks and um, what they are secreted by.
Mm-hmm.
So when we take HCG, for instance, we know that that's the first hormone that peaks, and is secreted by the corpus luteum.
Mm-hmm.
That's what maintains the pregnancy initially as the placenta is gearing up to take over. So by this is the 14th. So after about the 14th week, when does it peak? Around the 12th week or so, right?
8 to 10. 8 to 10. So
8
around
to
this.
10 peaks
Mm-hmm.
at 8 to 10. Okay, and then it starts to decline afterwards, and then declines till the end of pregnancy. But by this time, what is happening is that the placenta has taken over
Yes.
and maintaining the pregnancy. And so the other hormones, that's the HPL, estrogens, prolactin, progesterone, are all being produced by the placenta, and they continue to rise up till the very end of pregnancy. That's basically it.
Okay.
Or there's something else.
I think you, yeah, but there's a little omission. So initially too, corpus luteum is also secreting progesterone and estrogen. So
Okay.
before the corpus luteum degenerates, maybe let's say here, so this is where we can say that the corpus luteum degenerates at 14 weeks. That is where
Mm-hmm.
that is where the placenta starts taking over the secretion of the estrogen and progesterone.
Okay.
So because corpus luteum, what it does is to secrete estrogen and progesterone, but majorly progesterone. That is why you are seeing it here that the progesterone is the highest here. Mm.
Okay.
But
Progesterone. Yeah. Yeah.
but this HCG that is increased is actually coming from the placenta, from the cystotrophoblasts of the placenta, not corpus luteum. Corpus luteum doesn't
Which
secrete.
HCG? The peak,
Hello?
or as it's rising? Are you talking about the peak of the HCG or the rise, like where it
The
begins to
like
rise?
no, HCG itself from the starting
Mm-hmm.
is coming from the
Mm-hmm.
placenta. It's coming from the placenta.
Oh, really? Okay.
Yes, HCG is coming from the cystotrophoblasts of the placenta. You remember?
Right, right, right. Yes.
Yeah, so that is what causes this corpus luteum to be
To
sustained.
be maintained. Yes, 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 yes,
So
yes.
now, as the corpus luteum is maintained, what will happen is that corpus luteum will be secreting progesterone. That's why progesterone is rising here too.
Okay.
But with
Okay.
time, the placenta secretion of HCG peaks at 8 to 10 weeks, then it started dropping. Then about 21 weeks, its levels plateau. Mm. So now at this region where it's dropping, HCG is dropping, this corpus luteum has to go. But what will now take over the secretion of estrogen and progesterone? The placenta. So we can say that around this point where you don't have any ATG allele to maintain your corpus luteum, the placenta will continue to secrete the progesterone and estrogen that the corpus luteum used to produce. Do you guys understand? So it's just to
Yeah.
understand,
So
what is happening there. So if you guys want to figure it out, maybe, though I don't think they can ask you, I think what they can ask here is, okay, at what point does HCG peaks? 8 to 10 weeks, which is at this point. Then maybe peradventure they just ask you to identify this curve, which I think is very, very unlikely. But the way to just learn it is that the one that is the highest, is the human placental lactogen. We'll still discuss about it. Why the one that peaks the earliest from corpus luteum is progesterone. So you've already eliminated progesterone and your human placental lactogen. So you are left with estrogen and prolactin. So the one that follows human placental lactogen is estrogen. Then the third one is your prolactin. You already know that your progesterone is the last. You just trace it. Once you look at it from here, that the highest, or the last here, that's your progesterone. So you know your progesterone. You know the highest to be human placental lactogen, second to be estrogen, then you can figure the rest out.
So what produces the HPL and prolactin in the beginning? Is it still the placenta?
Yeah, so those ones are not
Okay.
being touched by corpus luteum. It is placenta that is
Right.
producing them right from onset. Right from onset.
Right.
Just like HCG too. All right. So um So physiological changes in pregnancy. So there are so many physiological changes that happens in pregnancy, and majority of them are secondary to the mechanical effect of the uterus as well as secretion of hormones. Now we'll be taking them one after the other. For the cardiovascular changes, you know that there's a formation of the placenta, and there is much blood flow from the mother to the fetus through the placenta. So in a way, the blood volume of the mother reduces. That triggers a renin angiotensin axis, brings about the absorption of more water, and the blood volume increases. It's important to know that the placenta is connected in parallel circuits. So if you guys try to calculate the resistance of parallel circuit, do you guys remember our cardiology when we're doing R plus R plus R equals R, then R 1 over R plus 1 over R? Do you guys remember that? What you get is
Mm-hmm.
that the one in which the resistance is corrected in parallel, we have less resistance more than the one that the connections is in series. Do you guys get it? Do you guys get what I'm saying? I don't know if you guys understand what I'm saying. Hello?
I know we talked about it in
Yeah.
cardiovascular, but
Yeah. Mhm.
Yeah, so
I
you
think I
guys,
remember it
let's just
now.
do like this. You are placing some vessels in parallel connection to another. Now, if you want to calculate the total resistance of that total connection, what you do is that you say that for the parallel one, the total resistance is 1 over R T equals 1 over R1 plus 1 over R2 plus 1 over R3. If you put a value, let's say 10 to each of the R, 10, 10, 10. If you find a total, average is 10. So 1 plus 1 plus 1, you get 3 over 10. So 1 over RT equals 10 over 3. That is 3.3. Compared to when you say in series, you know that if you want to find total resistance in series, you are going to do RT equals R1 plus R2 plus R3. That is 10 plus 10 plus 10, which is 30. So that means that the resistance is actually lower in parallel connection compared to series connection.
Okay. Yeah, we get that.
Yeah.
So that is why the systemic vascular resistance is lower, because the placental vessels are actually in parallel connection. So it's lower. That's why the afterload is lower. And of course, the reason why I told you the blood volume is, I share with the RAS. So that's why the blood volume is increased. So the increase in the blood volume brings about increase in the stroke volume, cardiac output, and increase eventual increase in placenta perfusion. So one of the other thing that also maintains, the cardiac output, especially in late pregnancy, is the heart rate. So the heart rate also increases in late pregnancy, because at late pregnancy the metabolic demand is very, very high. So you want to ensure that the cardiac output is, optimal. That's why you further, in addition to increasing the stroke volume, you want to increase the heart rate too, to increase the cardiac output at the end of the day. So of course, the large blood volume is going to dilute the proteins that are in plasma. So the oncotic pressure is going to be low, which explains the peripheral edema that they have. I said it that one of the ways by which you can have edema is that you can either increase the hydrostatic pressure or you can reduce the oncotic pressure. Hydrostatic pressure will always want to push fluid out of the vessel. Oncotic pressure will want to keep fluid within the vessel. So if someone has nephrotic syndrome and is losing protein, is losing all the oncotic pressure. So that means the hydrostatic pressure will be more, and there will be eventual extravasation of fluid into the tissues, causing peripheral edema. If there is heart failure, hydrostatic pressure is high. So it will be more than oncotic pressure, and there will be peripheral edema. So the reason why there's peripheral edema in pregnant people is due to hemodilution of the protein, causing a reduction in the oncotic pressure, bring about peripheral edema. So three things that we need to know: increase in this blood volume, a reduction in the stroke, in the systemic vascular resistance, bring about increase in the cardiac output. In later aspect of pregnancy, increased cardiac output is maintained by increased heart rate. Then there's also peripheral edema, which is experienced by the dilutional, phenomenon that they have. So causing a reduction in the oncotic plasma, colloidal, osmotic pressure, or the oncotic pressure, bringing about peripheral edema. Then endocrine. So what are the endocrine manifestations? People that are pregnant have increased secretion of an hormone that we call human placenta lactogen, or human placenta somatotropin. It's the same thing. So what that hormone does is to, in a way, inhibit or block insulin receptors. So there will be insulin resistance. Insulin will just be continually secreted, but it will not be able to act, just like what you have in type 2 DM. So there's increased insulin resistance. And you know that the normal function of insulin is to make sure that you are using glucose and conserving fat. So in that situation, you are going to have reverse, leading to increased burning of the fat, lipolysis, and the aim is to conserve your glucose and the amino acids for the fetus for growth and development, causing the mother to be burning fat and use that one for our own metabolism. And also, aside that, there's also increased, you know, enlargement of the pituitary gland because there's a lot of estrogen and progesterone acting on the pituitary gland to secrete prolactin. So, like we know, but the prolactin is not working, but it's sha being secreted. So that is why they have lactotroph hyperplasia at the end of the day. So you don't want this woman to suffer postpartum hemorrhage because you are scared of Ischian syndrome and the likes because of this pituitary enlargement. Then the estrogen and the progesterone that are abundant also, like we mentioned, increases the amount of the um the globulin. So the hormone binding globulin, like the thyroid hormone, the cortisol, as well as the sex hormone. So the three of them are elevated due to the effect of estrogen. Then what's the gastrointestinal effect, of pregnancy? Estrogen and progesterone, especially progesterone. Progesterone is even the one that is implicated. It causes relaxation of the muscles. So causes relaxation of the muscles of GI, bring about reduced GI motility, which eventually leads to constipation. It reduces the lower esophageal sphincter tone, relaxes it. So bringing about gastroesophageal reflux disease, and also causes relaxation of the gallbladder muscle so they cannot secrete bile. So if you cannot secrete bile, that means there is high tendency of gallstones developing. So those are the three things that we need to remember for GI: reduced gastric motility, reduced lower esophageal tone, and gallbladder stasis due to the effect of progesterone. Hematologic manifestation. So still the same phenomenon from the cardiovascular, the reduced perfusion to increase perfusion to the fetus, reduce maternal perfusion, brings about activation of the RAS, the addition of water. Plasma volume is too much high than the red blood cell mass. Even though the red blood cell mass also increases due to release of erythropoietin. So because you want to achieve increased oxygen delivery both to the mother and the fetus. So there's stimulation of erythropoietin to produce more red blood cell, but that increased blood volume that is formed is more than the red blood cell mass. So it eventually causes the additional anemia. So if you measure the hematocrit, it will appear low, but that's a false representation of what is actually happening. At the same time, people that are pregnant, they have um, um, absence of protein C, and they have high production of fibrinogen. So the high fibrinogen level and the low protein C level and Hz level brings about hypercoagulable state, and it is actually good for delivery so that you can minimize the amount of blood loss that will be lost at delivery. And of course, due to the metabolic activity as well as the synthetic function, the level of iron and folate is reduced. So you need to supply a lot of these nutrients. So folate is essential for DNA synthesis, formation of blood, formation of tissues, formation of the brain. Iron is also for blood formation, for bone formation, for so many, for teeth and all those things. So you know their requirement is too high. So that means you have to supply them because there's tendency of having deficiency of the two nutrients. So musculoskeletal, that's part of the hematologic manifestations or changes. Then musculoskeletal, number one, they release hormone called relaxin. Relaxin helps to relax the pelvic ligament so that you can have widening of the pelvic cavity to facilitate easy fetal descent during labor and delivery. Then lordosis is just something you can picture. Lordosis is just when you are standing and you are pushing your stomach forward. So what they are trying to do is that when someone is pregnant, the fetus is now formed, is now getting bigger, is pushing the stomach anteriorly. So you are because the line of gravity actually passes from the center downwards. So it's changing line of gravity towards the anterior aspect. So in response to that, the vertebrae is also going to move towards the gravity line of gravity by pushing the abdomen and the spine forwards too. So that is what we call the lordosis position that pregnant women assume. And I know most of you guys will be able to picture, the lordosis position. So you're just walking with your stomach being, it's like you are pressing your. Should I show us an image or because
Oh, we know
We
what it is.
understand you.
We
mhm,
understand.
so you guys are women, so you get it. Dr. Lushala said, he knows what is like. So yeah, skin. So skin, what are the changes in skin? We are familiar with this. The problem with skin is that there's abundant production of the melanocyte stimulating hormone, MSH. So the MSH causes hyperpigmentation, and this hyperpigmentation can present in the face, causing some hyperpigmented, marks in the face that are called melasma. In the abdomen too, they can have a straight line just from the pubic symphysis downwards to the pubic bone, which we call the linear nigra. That is just a straight line that is dark. Then areola, which is the dark aspect of the nipple that surround the nipple, the area that surround the nipple that is dark. Areola. So yeah, it's further darkened in pregnant people. The linear nigra is also, very prominent. And of course, they have striatum gravidarum due to the stretching by the fetus that is expanding, that is growing. So it causes damage to the collagen fibers within the dermis and dilatation of the vessels there. So, the estrogen is responsible for the vascular changes in the skin, like the spider angioma. So you see some, spider-like dilatation of the vessels, like looking like telangiectasias, then erythema, redness of the palm, which is, these two findings are, what you find in CLD. You guys remember? And the same pathophysiology is accumulation of estrogen that is not being cleared by the liver.
Yeah. Yeah.
Estrogen is not being cleared by the liver. That's why they have palmarythema and spider angioma. So estrogen that is accumulating in pregnant people is what is responsible in spider angiomas and palmarythema. While varicose is more of maybe effect of progesterone causing vasodilation of the vessels. And if you have venodilation, what happens? Anybody? Venodilation, what happens? What happens to the preload with
When you
venodilation?
have venodilation, the preload will decrease.
Exactly. So that's why they will say that you should not give nitroglycerin or nitrate to somebody with what? Can you guys remember your cardiology?
You shouldn't give nitroglycerin to somebody with yes, left. Is it left ventricular failure or
Okay,
right?
you tried.
Right
Who
ventricular
remembers? Who
hypertrophy. One
remembers?
of
Who
them
remembers one of the failures? Who remembers the one Dr. Valentiva is trying
is
to remember?
it's one of them. Yeah,
Is right. Hmm?
the right. Yeah.
Is right. So you don't give someone with right ventricular failure. You are just going to be increasing the burden on the left. So you don't if you don't give a drug that will reduce the what am I saying now? Because in the right, the blood will just be pulling within the peripheral circulation. It's going back to the IVC, SVC, pulling the air, pulling the lower lymph. You are now giving venodilation that will allow you to be pulling in the tissue. You have done nothing. So you are just worsening that heart failure by giving venodilators. Then,
Okay, but it's also contraindicated in a certain condition on the left. I
yeah,
don't
that's
know whether
that's what I want you to say.
was
That
it left
is
ventricular hypertrophy.
so that condition can
Left
also cause left ventricular hypertrophy, but it's not
is it a,
how
is
do
it a septum?
yeah, so that is your hypertrophic cardiomyopathy.
Yeah. Yes, exactly. I was about to say the
And
hypertrophic
you guys used to
cardiomyopathy.
move this thing. You guys used to say it anyhow on that page. Dr. Lushola
No,
particular. But that stuff is for Dr. Lushola. He's the one that says it every time.
right.
He has forgotten.
Is it a hypertrophic obstructive cardiomyopathy or just
Hmm.
hypertrophic cardiomyopathy?
Yeah,
HOCM.
hypertrophic obstructive.
Yeah.
So that is it. So, if you say that someone has, ideally, for you to be having majority of manifestation of the hypertrophy, the obstruction has to be there. So
Mhm.
if someone has
Mhm.
hypertrophic, obstructive cardiomyopathy, you don't want to give drug that will further reduce preload. So that is it.
Yeah. Yeah.
So you just want to give something that will just relax the smooth muscle to allow blood to be flowing out well.
Flow. Yeah.
Pressure
Yeah.
cardiac blocker or a beta. beta blocker to assist, with that. Yeah. So, if you give a beta blocker, you are slowing down the heart rate, you are increasing the time that you spend in diastole, you are increasing the feeling, you are increasing the cardiac output. So if you give a calcium channel blocker, you are doing the same thing as what beta blocker is doing. Then in addition, you are relaxing the smooth muscles so that you can relieve that obstruction a little, then you can achieve more perfusion. So, I'm just revising your cardio with you, just like that. Then, renal, progesterone again. Progesterone causes vasodilation, and renal takes about 25% of cardiac output, so there's more blood flow to the renal circulation, increasing the GFR. And of course, if GFR increases, there's clearance of majority of the electrolytes, your urea, nitrogen, creatinine, everything, they are reduced. But because of the fact that people that are pregnant can have, accumulation of the high amount of this human placental lactogen, which I told us that it causes insulin resistance. So that means that the amount of glucose is high in them. And again, coupled with the increased GFR. So there's high chance of them featuring glucose and protein. Of course, you are conserving glucose and amino acids. So both of them can find their way into urine. And although it's mildly, so you should not have your proteinuria more than 2 plus. If you're having proteinuria more than 2 plus, you want to investigate for preeclampsia. So now the mechanical aspect to it is now the fact that someone that is pregnant, there's high tendency of the uterus rotating to the right, so dextro rotated. So they can compress on the ureter and particularly the ureter on the right side, causing hydroureter and hydronephrosis, which could predispose to pyelonephritis. So there are so many reasons why pregnant women can develop pyelonephritis. One of them is this, and that reason is that the progesterone causes relaxation of the ureter, so that peristaltic movement that moves urine is lost. So the stasis of urine, and of course they have short ureters too, which could, urethra rather, which could allow entry of so respiratory
Why did you say it's more on the right? Why do you say that
yeah,
the compression is more on the right?
the ureters, the uterus is rotated to the right more in pregnant women. So
No.
that is it. So it compresses on the right ureter and brings about hydroureter and hydronephrosis. So that is it. Respiratory system, because of the fact that you have two people, the mother, the fetus, both producing CO2. So CO2 from the fetus will be moving through the placenta to the mother's side, and then you have to excrete the CO2. But what is the mechanism by which you now achieve the excretion of that CO2 is not by increasing respiratory rate. It's actually by increasing the amount of volume of gases that you exchange per minute. So if you are exchanging 500 mils, we have not done respiratory. When we get there, we'll talk about tidal volume. So if you are exchanging 500 mils of gases every minute, why not increasing to like 600 to take care of the excess load instead of increasing respiratory rate? So what actually changes in the respiratory parameters is the tidal volume, not the respiratory rate. So to compensate for the accumulated CO2. So there will be chronic hyperventilation, but the hyperventilation is in form of the increased volume of exchange, not the rate. So, and eventually to lead to respiratory alkalosis. Of course, you are losing CO2. So, yeah. So, yes. So I think I can, I've talked about this. Human HCG, it's produced from the cytosol of the placenta. The main function is to maintain corpus luteum to secrete progesterone for the first 6 to 10 weeks of gestation, acting like headache, like I talked about. So if you don't have progesterone, there will be abortion at the end of the day. So it eventually moves from the corpus luteum to the placenta, after the 8 to 10 week that we talked about. So immediately after it peaks, the placenta takes over and continues, the secretion of the progesterone while your corpus luteum degenerates. So placenta also synthesizes its own estriol. That's the estrogen form of the placenta, estriol. Hmm? What else did I say is peculiar to this estriol? Anybody?
You said it increases by 1,000-fold during pregnancy, so it's a potent indicator,
For
right, of placental function.
years and eventual fetal well-being and fetal well-being. So
Fetal well-being. Okay.
so yeah, so its placenta continues to synthesize its own estradiol and progesterone while the corpus luteum degenerates. So Immediately after the 10th week, corpus luteum goes off, and that estrogen and progesterone synthesis is taken up by the placenta. So you can use it to detect pregnancy as it appears early in urine. So by the second week, you see it in urine. By the first week, you see it in blood. And of course, I've explained this. So it has identical subunit as LH, FSH, and TSH. So state of high HCG like a cholangiocarcinoma can cause hyperthyroidism because it will be acting on TSH receptors to stimulate the thyroid hormone. Why beta subunit is unique. So, pregnancy test detect the beta subunit, not the alpha subunit. So there are some conditions that increases HCG. Number one, um, multiple gestation. Multiple gestation can cause polyhydramnios, can cause elevated HCG because it means you have two placenta secreting HCG in for one woman. So the level of HCG will be high. Hereditary chorocarcinoma, they are gestational trophoblastic disease. So they affect the trophoblast. I know that HCG is coming from the trophoblast. So there's high secretion of HCG in chorocarcinomas and hereditary as well as pregnancy, as well as Down syndrome. So out of the trisomies, it is only trisomy 21 that secrete HCG. In Down syndrome, HCG increases. Uh, HCG increases. So the level of HCG drops in Edwards and Patel. Edwards and Patel, they have low HCG, as well as ectopic or a failing pregnancy. So the way you want to monitor the level of an ectopic pregnancy is to monitor serial monitoring of the HCG. So with time, if you see that the HCG is dropping, you know that okay, this ectopic pregnancy is likely to terminate by itself. So, but if it's still increasing, you know that you are not doing a good job. So that is it. So, but ideally, level of HCG, usually drops in a failing pregnancy and Edwards syndrome and Patel syndrome, unlike Down syndrome that you have elevated HCG. Then I've talked about human placental lactogen, what it does. It's also known as human chorionic somatotropin. It's secreted from the cisterna of the placenta. What it does is just to achieve insulin resistance, blocking the insulin resistance so that they cannot work, so that it cannot metabolize glucose. But rather, you want to use um, fat. So the mother is using fat for her own metabolism. So there's lipolysis, there's fatty oxidation, and because of the fact that there's insulin resistance and the pancreas do not stop producing insulin, it eventually leads to the gestational diabetes. So there are so many factors that can lead to this, but one of them is, by the activity of the human placental lactogen working together with so many hormones like cortisol, and the other diabetogenic hormones. So yeah, so maybe I should just round up with the ABGA score. Then we talk about there's still a lot to cover. Still a lot. Okay. So ABGA score is something we are familiar with. So it's just an assessment to know the status of a fetus following delivery. So we want to know the status of the baby, you know, um, following delivery and after resuscitation. So it is called, the maximum is the minimum is 0, the maximum is 10. So anybody less than 3, any baby that gets less than 3, there's a high chance of baby developing cerebral palsy. So between more than 7 is actually good. So it means that the baby is, doing well. So yeah. So so what are the parameters? The parameters can be coined from the name APGAR, APGAR. So A for the appearance. So how does the baby look like? Is it pink or true? You award the person's score of 2. If you look at the body, it's only the extremities that is, blue. The body is pink, but the extremity is blue. 1. Everything is blue or true. So the way you assign the one of score is that you look at the extremities for the blue. Don't forget blue extremity. I don't. If they ask you a question on Abga, you likely get it. It's very straightforward. I've not seen any question on Abga before. So the pulse, all these ones are all or none. So it's either you have a pulse more than 100 or you don't have. So if you have a pulse more than 100, give him 100. Give him 2. If it's nothing, 0, give him 0. If it's in between, 1. Grimace 2. You try to stimulate the baby by maybe pinching. If the baby cries and tries to pull away, That's good grooming. So it's true. If the baby just squeeze his face or add a poor cry, that's like one. No stimulation, no response to stimulation, zero. Activity. If the baby is actively moving, moving all the limbs, extremity, everything, active movement. If the baby is just flexing only the arms and the leg in a still position, that's one. No movement at all. No movement at all, zero. Respiration is just like okay, if there's a strong cry, two. If the breathing is slow and irregular, one. If there's no breathing at all, zero. So it's either the respiration is very strong or there's no respiration. So if there's no respiration, zero. If there's no movement, zero. If there's no response to stimulation, zero. If there's no pulse, zero. So you can easily separate your zero parameters. So if there's a strong cry, you give, two for respiration. So if the breathing is slow and irregular, you give one. So that's that. So I've said it. If the Alga score is less than 3, there's a high chance of the baby developing neurological damage. So you want to evaluate further and see what you can do. But there's a high chance of baby developing cerebral palsy. So yeah. So if it's more than 7, it's fine. So neonatal birth weight, so low birth weight and high birth weight. So they've classified it. Before in 2022, it's usually only low birth weight. So they've added high birth weight now. So low birth weight is when you have birth weight of less than 2.5 grams. 2.5 kg or 2,500 grams. If it's more than 4 kilogram or more than 4,000 grams, that is macrosomia. So what are the causes for low birth weight? So there are so many causes for low birth weight. Prematurity is there. Anything that can cause fetal growth restriction is there. Maybe uteroplacental insufficiency, maybe thyroid problems, maybe sickle cell in pregnancy, infection, touches infection and chromosome abnormalities, fetal growth restriction, so they can cause low birth weight. High birth weight can be fetal or maternal. It can be constitutional. That's the way they are in the family. The mother, the father, they are short. Yeah. Or they are, sorry, I said they are short, they are very big. So there's a high chance of the baby too being big. It can be genetic or constitutional. If the mother is obese, there's a high chance of that baby too being obese. If the mother is diabetic, there's a high chance of the mother being diabetic. You know why? Action of insulin. Insulin is an anabolic hormone. So insulin is an anabolic hormone that will cause preservation of fat and utilization of glucose. So all the fat is being deposition and make the baby very big. So what are the complications for low birth weight? That's the sudden infant death syndrome. They can die anytime between the point of delivery and 1 year after delivery, and share with high, mobility. Then for the microsomia, it's just more of, maternal injuries during delivery, like, you know, herpes palsy and the likes, and when you are trying to pull the baby out, shoulder dystocia, you know, and whatever. So that's that. So guys, I think we are going to stop here, and we are going to continue.
Thank you. When are we going to
Thank you.
solve questions?
Thank you.
Yeah. So I've been thinking about it. I just want us to cover. You guys can see that what we have been doing so far, we've not really got into pathology, and the few questions I picked,
Yeah.
listed it on the
No, this reproductive system is much. Male, female, children, everything.
is
It's
much,
just basically O and G.
is much, is
Right?
much.
And then they put some pediatrics and call it reproductive system.
Mhm.
Oh my goodness.
I
Don't
remember
say
that
that. You're
this
making
was
me laugh.
this was this was something that you know that you guys need to pay attention to. I know you guys
Which
just
one?
ignore it.
Dr. Babali. Sorry, what are you saying?
So I'm just trying to say it. Okay, let me just mute. Okay, so let me just stop.